Module number 3 of Milestones in Algology focuses on myth, biases, misconceptions, as well as reflecting on some logical considerations. Several years ago, I read some of Ben Rich's writings that greatly attracted my attention. Ben Rich is the professor and chairman of the Department of Bioethics at the University of California at Davis. He has had several very interesting professional careers. As a doctor of jurisprudence, he was first a lawyer and later a judge. He then decided to return to graduate school and receive a PhD degree in bioethics. His major fields of interest are pain medicine and palliative care. I was amazed how greatly we agree on these subjects, considering that we come from very different backgrounds. There is, however, at least one great distinction between us. He is a much better and more convincing speaker than I am. Therefore, I asked him if I could use several of his remarks in my presentations, and he kindly gave me the permission to use them.
Pain management practice presents the most glaring example of a disparity between the current state of medical knowledge and the prevailing custom of medical practice. It's hard to imagine another aspect of medicine in which such a profound failure to incorporate current knowledge into medical education and medical practice would evoke such an underwhelming response, both from within and without the profession.
The lack of integration of current knowledge is responsible, among other problems related to the poor treatment of pain, to the poor and even improper terminology, as well as the development and perpetuations of myth, biases, and misconceptions. I have already explained at the introduction of these milestones that the correct words to describe the medical discipline that studies and treats the experience of pain should be algology, from the Greek words algos, meaning pain, and logos, the study of. Just like other medical disciplines use terminology of Greek origin, such as anesthesiology, endocrinology, neurology, oncology, rheumatology, just to mention a few. The use of the word algology to define the study of pain is not new. Dr. Benjamin Crew, an American pioneer in the field of pain therapy, was concerned that calling the study of pain management, as Bonica did in 1953 with the publication of his book, The Management of Pain, would demedicalize the discipline. In 1983, Ben Crew founded the American Academy of Algology. But in 1987, under a new leadership of the Academy and in a regressive move, the name of the organization was changed to the American Academy of Pain Medicine. I recall a few conversations I had with John Bonica about the name of this discipline. He explained to me that he believed that algology was the correct word to use, but when he started the movement to popularize the need of more attention to the treatment and the study of pain, he wanted to concentrate all his efforts to that end. He believed that using the word algology, a word already wrongly used to describe the study of algae, would detract too much effort from his major purpose of focusing on pain. In parentheses, the reason that algology is the wrong words to describe the science that studies algae is that it is formed by words derived from two different languages. Alga is Latin and logos is Greek. The correct words for the study of algae should be psychology, where psychos is the Greek word for algae. Bonica felt that calling it pain management, it would underscore his firm belief that pain needed to be treated by using a multidisciplinary approach, and that the discipline would attract not only physicians, but also psychologists, nurses, physical therapists, occupational therapists, pharmacists, and other healthcare professionals. He was a firm believer that for the movement to succeed and flourish, the largest number of healthcare professionals should be involved. As he would often say, his philosophy was based on beating the drums to attract attention, as he remembered that in his youth, the small circuses coming to town would announce their arrival and attract attentions with a parade preceded by some members of the circus beating the drums. Also, Bonica, being an opera lover, certainly remember the first scenes of Leoncavallo's opera Pagliacci. The 2011 Institute of Medicine report on the relief of pain in America and the federal agency publications that followed. In 2014, the NIH publication, The Role of Opioids in the Treatment of Chronic Pain, followed in 2015 by the Health and Human Services report from the National Pain Strategy, have, 60 years later, partially fulfilled Bonica's dream. Pain is finally recognized as a significant public health problem in the United States. This having been accomplished, I believe the time has come to give the management of pain its proper medical name, algology. An even more derogatory, delegitimized word associated with this medical discipline is the frequent use of the word painkiller to denote a medications, usually an opioids, that relieve pain. The appropriate and correct words for such medications is analgesics. The word painkiller has an interesting, colorful, but not reputable medical history. The word painkiller was coined around 1850 and later patented by Perry Davis to promote the sale of Davis vegetable elixir, which he had developed by empirically mixing the extracts of various plants having medicinal effects. He originally mixed the elixir to treat his own overwhelming illnesses, and then he started to sell it as a magical elixir to treat pain and many other diseases. It was marketed as good for man and beast. The word painkiller is misleading. Perry Davis' elixir did not kill or eliminate pain. It may have abolished mild to moderate pain, but at most it would have reduced severe pain, just as our present analgesics do. Perry Davis' elixir provided relief of pain, cough, and dysentery, very common maladies of his time, mostly through the medicinal properties of opium, the major component of his elixir. He very effectively marketed his elixir, and the word painkiller became common in the American idiom to describe any pain-relieving drug. Perry Davis, however, contended that he had patented the word painkiller only to describe his elixir, a right which was recognized by the courts. However, it is very disturbing, and there is at least a slight irony, that 170 years later, with an enormous amount of investment and great advances in medicine, not only society and the media, but even a federal agency like the Center for Disease Control, the CDC, would unprofessionally continue to perpetuate the use of a misleading, unscientific words like painkillers. A frequently debated topic in algology and some other medical discipline is the definition of addiction. The NIH, the National Institute of Health, defines addiction as a chronic, relapsing brain disease characterized by compulsive drug seeking and use despite harmful consequences. The NIDA, the National Institute of Drug Abuse, continues to use the term addiction to describe compulsive drug seeking despite negative consequences. Therefore, there is no addictions when a drug properly prescribed and used is able to decrease the symptoms of a disease, improve functionality, and the harmful or negative consequences are minimal and treatable. However, there are recurring misconceptions about pain, the use of medication to relieve it, and addiction that even a highly respected, widely supported TV broadcasting company, the Public Broadcasting Service, or PBS, included in at least one of their broadcasts a wrong and misleading message about addictions to analgesics. The airplane crash of Howard Hughes is depicted in a segment of the program History Detectives, broadcasted on August 5, 2007. In it, the reporter states that Howard Hughes had a lifelong addiction to painkillers. This is a synopsis of the program. In 1946, Howard Hughes crashes his test plane in the city of Beverly Hills in California. The reporter states that the crash scars Hughes physically and mentally, marking the beginning of his lifelong addictions to painkillers. He further states that Howard Hughes barely survived the crash. A witness of the crash reported that Howard Hughes ended up with a crushed chest, multiple broken bones, second and third degree burns all over his body.
July 7, 1946. The world's fastest military spy plane is about to launch on its maiden voyage. And the test pilot is as extraordinary as the plane itself. Howard Hughes, billionaire Hollywood playboy and aviation wizard. But 75 minutes into flight, the plane suddenly plummets at over 125 miles an hour, diving into a wealthy Beverly Hills neighborhood, smashing 3 homes and nearly killing Hughes. The crash scars Hughes physically and mentally, marking the beginning of his lifelong addiction to painkillers. Barely survived.
He ended up with a crushed chest, collapsed lung. He had multiple broken bones. He had second and third degree burns over all of his body.
The question that needs to be asked and answered is, was Howard Hughes addicted to opioids? In 2007, Dr. Forrest Tennant published a comprehensive analysis of Howard Hughes' medical history. Hughes was an eccentric personality, but this predated his use of opioids by many years. After the crash of 1946, Hughes suffered severe, intractable pain from the rest of his life until he died 30 years later. He is reported to have suffered severe allodynia, and in the privacy of his room, he often did not wear any clothes, since the light touch on his skin of even his shirt or underwear would trigger severe pain. He injected several times each day the prescribed codeine and used both acetaminophen and non-steroidal anti-inflammatory medication to treat his pain. He was very functional until 1972 when he fell and broke his femur. The added pain from his further injury confined him to a bed until his death 4 years later. When he died in 1976, he was one of the richest persons in the world. It can be stated that his continued use of codeine did not impair his functions, and his continuous and compulsive use of analgesics were dictated by the need of obtaining some relief from his severe chronic pain and allowing him to be functional. Therefore, he cannot be labeled as addicted to his analgesic. Let us make some logic deductions. If we believe that Howard Hughes was addicted to the analgesics he used to treat his chronic pain so that he could control his disease, then we must also believe that I am addicted to beta blockers that help to control my hypertension, or to statins that control my high cholesterol. And should we also consider a diabetic patient addicted to insulin because if he or she does not use it several times a day and titrate it to the desired blood glucose level, the diabetes of this individual will not be properly controlled. The only major differences among these four diseases is that hypertension, high cholesterol, and diabetes are diseases with objective symptoms, while pain is subjective. Just because pain, up to now, cannot be objectively measured, it does not mean that it is less serious than objective symptoms. Sadly, it means that usually healthcare professionals do not trust their patients. Let us reflect on some further logical deductions. If an individual inflicts pain to himself or herself, we consider that person to suffer from psychopathology or a personality disorder. A patient with severe physical pain must, to follow normal behavior, aggressively seek pain relief. If a drug provides pain relief with no serious side effects, even the persistent search and use of the drug for analgesia is normal behavior, as the consequences of an opposite attitude will result in severe pain, a sign of a personality disorder. In search for pain relief, a patient may ask to undergo a major, at times mutilating, risky surgery, even without any certainty of a beneficial outcome. This request is accepted by society and the medical profession. Often, many surgical procedures are performed in an attempt to relieve the pain, as attested by many patients who undergo several back surgeries for recurring, incapacitating, unrelieved back pain, or other patients who undergo many other invasive procedures for pain relief. Today, on the contrary, a patient with severe incapacitating pain who is able with the judicious use of analgesics, most often including opioids, in conjunction, when indicated, with physical and psychological therapies to decrease the pain and significantly increase functionality, will find it difficult to find the physicians willing to prescribe the needed medications, as well as insurance companies not willing to pay for adjunctive therapy. Often the patients will face suspicions and at times be considered a drug seeker and even an addict. The question to be asked is why major, multiple, risky, expensive, and at times ineffective surgeries are acceptable, but medical, physical, and psychological therapies are often denied. This consideration ends module number 3. Module number 4 of Milestones in Algology will discuss the major barriers for the advancement of this medical discipline. The major barriers are pain assessment, pain education, and pain research.